welcome to the EMSNation podcast. I'm your host, Faizan Arshad. We continue along our series in regards to the World Trauma Symposium, bringing you high-quality FAWM ED-style lectures from EMS World Expo, Las Vegas. Our next lecturer is none other than Julie Chase, who is well known to the trauma sphere due to her contributions to pre-hospital trauma. And she brings a high-impact lecture that should potentially be practice-changing for many folks out there. Controversies and evidence base of needle decompression, where we need to go in the new 21st century. So she really digs into the current state of the evidence on needle decompression, discusses a lot of the limitations and challenges, as well as the new current guidelines included in all the new NAEMT package suite from TC3, TECC, as well as PHTLS. So hang tight and tune in to Julie Chase.
All right, so we're going to talk a little bit about needle decompression, tension pneumo, some limitations of needle decompression, a little bit about finger or simple thoracostomy, indications, contraindications, and risks of procedure, and how it might be applicable in the pre-hospital setting. So worldwide, 5.8 million people die every year from injuries. And we know that Americans 1 to 44 years of age, trauma is a leading cause of death. So from those statistics, in the U.S., thoracic trauma accounts for about 16,000 deaths a year, and it's about the same in the U.K. at 17,000. So if you were to Google the definition for tension pneumothorax, you would find that there's no single universally accepted definition. And as we go through the slides here, anytime you see a reference to Frank Butler, 2017, he was kind enough to lend his notes and presentation from a recent COTC meeting. And they're talking about needle decompression. And it's a work in progress. There's been no changes and no decisions made. They're just discussing it. So as we know, when it comes to tension pneumo, we know that there's an injury to the chest wall and or lung, and there's a resulting accumulation of air into the pleural space and resulting pressure that essentially crushes the heart and the great vessels and is a life-threatening condition. So depending upon whether the patient is being assisted in their ventilations or they're breathing on their own, the signs and symptoms can be a little bit different from person to person. But what we do know, one of the two main ones that we can hang our hat on is an individual that has known or suspected chest wall trauma and progressive respiratory distress. So I know there's a whole other laundry list that you guys can think of immediately, including changes in level of mentation, anxiety, agitation, shock, hypotension, and then the favorite ones we love to talk about, jugular venous distension and tracheal deviation. All right, so we know that we need to have a starting place for equipment choices, and we really should be using appropriate needles, right? So since 2008, the recommendation from the COTC has been a 3¼ inch needle, 14 gauge. I'm not asking you to necessarily dime out an agency or confess. Has anyone recently seen needles that are shorter than that, 2-inch needles that are in kits that are meant to be decompressing the chest? Dr. Butler was interested if any hands might go up. So that's good. We don't want to be using too short of a needle. So as things stand right now, for needle decompression, we have a couple different locations. So who uses second intercostal space, midclavicular line, as their primary go-to site? Okay, very good. So you'll remember that Dr. Pollack was speaking earlier about ATLS changes, and that has changed in ATLS so that the preferred site is now the 5th intercostal space anterior axillary line. So we know the steps for treating tension pneumo, and making sure that we do it correctly and that we reassess to make sure that they don't retension. So this is a really neat video. It is available in the TCCC medical personnel curriculum, and you can look at it there. And it is basically, it's an internal fluoroscopic view of a real-time needle decompression on a live casualty from the Ukraine. It's impressive, isn't it? It's one thing to have the needle decompression mannequin and to go through and talk about what it looks like. To actually see it, I think is very neat. So we've just seen that we know it works, and we've seen that it works. Sometimes it doesn't always work, though. And some of the things we talked about earlier, Dr. Pollack mentioned. So inappropriate choices for needle length. Inadequate training and proper technique, which we're going to talk a little bit about. Body mass index is an issue. It's something that we need to talk about. And then obviously catheter kinking or occlusion with tissue or blood. All right, so this is very interesting. This was an observational study done in 2005, and basically asked 25 emergency room physicians to verbally articulate where they had learned to do needle decompression. Okay, and so most of these, I think 84%, were ATLS certified emergency room physicians. And so they asked them, okay, where do you decompress the chest? 22 of them said second intercostal space, mid-clavicular line, okay? 15 of them went to medial. So you can see, if you look up on the slide there, all the dots. They were asked to show on a human volunteer where that site was, okay? And then a couple picked pericardial centesis site. I'm not really sure what happened there. And then the other was anterior axillary line. So this is what I'm gonna ask you. So I want you to think about your tension pneumo task trainers, your needle decompression trainers, and tell me that that doesn't look vaguely familiar, right? It's like when one person inserts a needle, then everyone else is like, oh, I know, it goes right here, okay? So if emergency room physicians are capable of going to medial, what about the rest of us, okay? So I think we're pretty good at finding the second intercostal space, whether you're using the 2 or 3 finger down from the clavicle or you're using the angle of Louis or whatever. But I'm not real convinced that we always find the actual mid-clavicular line, and we're staying outside of the box. Okay, so as I said, since 2008, the recommendation has been a 3 1/4 inch needle or 8 centimeters, 14 gauge, as recommended by the COTC. So you'll see one that looks a little bit different than the other, and I haven't had a chance to actually get my hands on this and really look at it. It just looked interesting to me. So it's made by H&H, and it's called the Enhanced Pneumothorax Needle. Has anyone actually looked at it? Okay, I would like to as well. So what do you notice about it instantly? Yeah, there's not the catheter there. So, and this isn't, I'm not saying go out and buy it, I'm finding it interesting. It's also a little bit longer, it's 8.6 centimeters instead of 8. So maybe something that you want to check out. I know I do. All right, so body mass index. This is a little bit scary, but it's something that we have to talk about. In the US, more than a third of adults are obese. So they have a body mass index of 30 or higher, okay? And then 1 in 6 kids are falling into this category too. So what does that do to the chest wall thickness? that Dr. Pollack already talked about. It's increasing it, right? Yeah. So if we know that this is a challenge, initially I think it was more focused on young, fit military males and just the amount of tissue having to go through. But tissue, the needle has to go through that to get to the pleural space. So even when it's done correctly, and even when the needle has reached that pleural space, just any kind of casualty movement, to include movement of the chest wall after the procedure is done, can displace it. All right, so this basically just talks about how the anterior axillary line, the fifth intercostal space, is 1.3 centimeters thinner on average, according to this study that was done. And it was 680 patients, 16 years of age or older. They did chest CTs, and to no surprise, the chest wall is thinner at the fifth intercostal space. So in addition to it being thinner wall there were some associated injuries with second intercostal space, midclavicular line. If you think about the great vessels that are there, if someone has a tendency to aim the needle towards, the important bits, the heart, that can result in injury. And there was a 2003 report documenting 3 patients that were decompressed at that site that had life-threatening internal bleeding as a result. So it's less effective and a little riskier. This was really interesting. Okay, so 2015, they asked 25 Navy corpsmen they wanted to see if there was a difference between their ability to decompress the chest, either fifth intercostal space or second. And so they timed them. And they did a timed insertion of 100 needles into 25 cadavers. The insertion time was the same. Okay, so it wasn't slower. They were the same, essentially, from fifth intercostal to second intercostal. But what they did find was it was much more accurate, and the folks reported that it was easier. They felt like it was easier to do. All right, so should we consider, and we're talking about adults now, not kids, switching so that the preferred site is the fifth intercostal space anterior axillary line. And we know from this morning that Dr. Pollack has told us about the update for ATLS. So right now, the COTC, they're just talking about it. The Committee on TCCC, they're just discussing it. There's been no change. They're just looking at it like they do with everything. So, all right, so this is my question. If we're gonna keep the second intercostal space, even though we know it's thicker, it's a little riskier, maybe we need to consider reframing how we're teaching it. Because clearly, we can say the mantra, midclavicular line, but it's not translating into the correct site. So maybe we need to identify the midsternal line and the anterior axillary line and splitting the difference. Or the way that we're phrasing it, saying at the nipple line or slightly lateral to the nipple line. And just thinking about how we're asking people to frame it in their mind. So. All right. So initially, I started reading about, there's all this talk on blogs, right? Everyone's talking about finger thoracostomy, and ooh, so exciting. So essentially, it's just the first steps in inserting a chest tube, but you don't insert a chest tube. Instead, you put an occlusive dressing over the surgical site. So it's been around for a while. It was talked about since 1995. By London's Air Ambulance Service. But the takeaway from this as we get into it is that their crew is a physician and a paramedic, okay? All right, some examples of indications, contraindications, and risks for finger thoracostomy or simple thoracostomy in some of the protocols and literature: multiple rib fractures, flail chests, diminished breath sounds, subcutaneous emphysema, traumatic arrest, shock of unknown origin, shock in the presence of thoracic or abdominal trauma, shock while providing positive pressure ventilation. So some indications there. Contraindications: someone that's not in shock or someone that's been in arrest for more than 10 minutes. Some risks that need to be considered: Obviously, sticking your finger in someone's chest is a little invasive. It can be time-consuming for folks that are not experienced. There's a good video, I think his name is Dr. Cliff Reed, who does, it's on YouTube, a field finger thoracostomy, and he makes it look easy and it's fast, but he's also what we like to call a doctor. So makes it look easy. Obviously, we can cause some problems if we do it inappropriately. Pneumothorax, hemorrhage, perforation into abdomen, and infection. And then obviously, because there's no tube, it's the first steps in the chest tube. There's no tube. It may occlude anyway during transport. And then also, just the procedure itself may cause some injury to the provider, bone fragments and cutting themselves on scalpels and stuff. So, all right. So what I've read is that, yeah, this finger thoracostomy is something that appears to be safe and effective in the pre-hospital setting, but most of the examples that we're using are physician-based services. So we don't have a lot of information beyond that. So that would be somewhere that we could start, is looking at helicopter services that have different crew formations that are using it successfully currently. So that would be a good starting place, and also too, it might be better for areas of the country where the transport times are longer, more remote areas where the risk of retention is high, and then obviously you're going to need buy-in from a medical director and really the community as a whole, from area hospitals with training and education, and then you're going to have to put the work in to demonstrate competence. So that's what my takeaways are. But before we jump off the deep end and start doing fancy stuff, let's make sure that we're doing needle decompression properly in the first place. Let's make sure that we are teaching it correctly, that we're asking folks to demonstrate it regularly and doing that correctly, and that we consider modifying our protocols to match ATLS new preferred site as fifth intercostal space, anterior axillary line. That's all I have.
Thank you guys so much for tuning in and for your support of the EMS Nation podcast. We very much appreciate you listening in and making the conscious decision to upgrade your skill set and deliver the highest quality care to your patients. We also value your feedback and would love for you guys to leave a review on iTunes so that we can continue to share this podcast with all the pre-hospital colleagues on this planet, and let people know, regardless of what your favorite listening style is, we are available on iTunes, the Android platform, and we also recently joined Spotify. So please tune in to the next episode of EMS Nation. Here is a salutation from the Pre-Hospital Trauma Committee of the National Association of EMTs.
I'm Andy Pollack, medical editor for PHTLS 9th edition. My full-time day job as chairman of orthopedics at the University of Maryland, but I'm also the medical director for the Baltimore County Fire Department and a special deputy U.S. Marshal. I can tell you that we are clearly looking forward to the upcoming publication of the 9th edition of the PHTLS textbook. Our authors have been hard at work editing the prior version and adding new content to ensure that we have thorough coverage of all the topics that are important to pre-hospital care providers at all levels, and that we've clearly established the evidentiary basis for the statements made and the conclusions drawn. We'll be rolling out the new edition at the World Trauma Symposium in Nashville this coming October, and we hope you can be there for this exciting event.
My name is Jesse Bidlow. I'm an anesthesiologist and EMS physician from Switzerland. I'm in charge for the airway chapter of 9th edition of PHTLS. Actually, I think it's very important because there has been a lot coming out in the last years about airway management, and not only in advanced airway stuff, but we have come to recognize the importance of basic airway management. So we have a lot in store, not only for big time ALS providers, but for each and every EMT on the street. So I'm very, very excited about this 9th edition we're going to present in Nashville.
I'm Alex Eastman. I'm the medical director of PHTLS, and it is a real pleasure to follow in the footsteps of some giants and friends who have filled this role before me. The theme for the 2018 World Trauma Symposium is New Threats, New Solutions. And at a time when the world seems a bit uncertain, when EMS providers are being asked not only to face novel threats but to respond to them, we felt like it was our responsibility to bring a conference together that helps not only introduce the 9th edition of the PHTLS program, but brings you, the EMS provider at all levels, a better ability to respond to the novel threats that are out there. So I hope that we will see you in Nashville. We'll promise you an unparalleled program that I think you'll enjoy. So with that, I'd say thank you for listening, and we'll look forward to seeing you in Nashville.
This is the Pre-Hospital Trauma Committee wishing everyone a safe tour.